Hello everyone. I welcome you all on this session of integrated series for next. As you know, according to the latest pattern, there are more and more clinical questions expected, and one of the important topics in ophthalmology that you can get a clinical question is the proptosis. So today I am very happy to present before you the integrated session of ophthalmology with the radiology. So we are there with Dr. Rajat. Welcome, Dr. Rajat.
Thank you, Dr. Niha.
So first of all, we would like to have some words from you. What do you think? How much important is this integrated art of learning that we have taken the initiative?
Dr. Niha, when we talk about this new initiative, I feel that it is very, very helpful for the students because the way that the pattern is changing, what we are realizing is that now we are not limited to a particular subject. More and more, the examiners are realizing that the patient doesn't come with a subject. Patient come with a disease and with a symptomatology. And learning the, the subject with that symptomatology plays an extremely important role. So going by these integrated sessions, like when a patient has presented to you with a particular symptom and what could be the problems, I think would be very, very useful for the students.
Yes, so definitely I think we're going to help the students by this way of learning, and if they have gone through today's session, I think no question will be there in the examination related to the proptosis or the exophthalmos which will be left unanswered. So let's begin with this. Starting with the proptosis, I think first you go if the very basic definition that proptosis is nothing but the forward protrusion of the eyeball. And if you look at the word itself, it is always easier to learn the things from the words itself. See, splitting the word, it is prop and ptosis. So it is the propping of the eyeball, and ptosis means it is related to the eyelids. So propping of the eyelids outside the propping of the eyeball outside the eyelids from the lateral orbital margin is what you call as proptosis. Yes, and the second word is the exophthalmos. So exophthalmos, most of the time we are restricting this term for the thyroid eye disease. Now, though nowadays there is a liberal behavior, and books are also using both of these terms interchangeably, but I would still say that it will be definitely better if you restrict this term for your thyroid eye disease. Okay, so we have got exophthalmos, and what will be the opposite of it? This will be your enophthalmos. Now, there are certain conditions where there is pseudoproptosis. So actually, you do not have the proptosis
Dr.
there.
Neha, are you sharing the screen?
आपको नहीं दिख रहा क्या?
No, I think you are not able to. I can't see your screen. So check it again.
Okay. अभी देखिएगा.
Yes, not is visible.
All right. So going by the name itself, the proptosis. So what is proptosis? It is propping of the eye outside the eyelids. So prop and ptosis. Okay. So proptosis is the forward displacement or the protrusion of the eyeball. And if you go by the definition, it is more than 21 mm from the lateral orbital margin. Now, when you have got unilateral proptosis, you can always compare it from the other side. And if there is difference of 2 mm from the other side, that is also your proptosis. If you have bilateral proptosis, go by the definition more than 21 mm from the lateral orbital margin. Now, yes, we have got one more terminology for this, that is exophthalmos. Now, though they are used interchangeably nowadays, but still I would say that you should always restrict it for the thyroid eye disease. So we have proptosis and the exophthalmos. Exophthalmos opposite is inophthalmos. So sometimes what happens, one eye may be having inophthalmos, due to which other eye will be showing you the relative proptosis or the pseudoproptosis. So when you are solving the clinical questions, always take care and keep this in mind that there is always a possibility of pseudoproptosis. So if you go by this, I think it will be easier for you guys to solve the clinical questions, because sometimes you are not getting any evidence of exophthalmos, but side by side question says proptosis, proptosis. So that may be inophthalmos in the other eye. So what are these things? A false impression of the proptosis. It could be buophthalmos, the congenital glaucoma. We could have high myopia, contralateral ptosis. So if I am having a ptosis in my patient in one eye, other eye will be looked to be proptosed, or it could be contralateral inophthalmos. So this would be your pseudoproptosis. Now, going by some of the very important types of proptosis, like if I am having an acute proptosis in my clinical scenario, then what are the things I should think? I should be thinking about the emphysemas, the orbital hemorrhage. But if they are talking about intermittent proptosis, you have varix, you can have orbital edemas, you can have recurrent orbital hemorrhage, or we can have pulsating proptosis, which could be found in keratoconcavenous fistulas. We have aneurysms, meningomyelocele, we have traumatic or operative hiatus. Now, in list, we have got so many things, but obviously, if you go by the clinical scenarios, you want something which will click you, that if this is given, what should I think? So we will be concentrating on some of the most important topics, and then I'll be requesting Dr. Rajat that he will be helping by the imaging of these conditions also, so that you have no doubt left about the diagnosis. So if you talk about the intermittent proptosis, we'll be talking about the orbital varix today. Pulsating proptosis, very, very typical, and many times in AIMS also, we had a question on keratoconcavenous fistula. We'll be talking about this. Then we will be talking about the tumors. Now, tumors, though they are not very common, but of course, if you go academically, going by the previous trend of questions, we have a number of questions asked on the tumors. So we'll be talking about some of the tumors like rhabdomyosarcoma, we have gliomas, and we'll be seeing that what kind of proptosis they are going to create, whether it is unilateral, bilateral, whether it is painful, whether it is painless, whether it is acute, intermittent, pulsating, axial or non-axial. These are some of the important criteria. Now, how to solve the clinical question? Now, it is not just about the proptosis. See, the most important thing is, while you are solving the clinical questions, you should have the clinical acumen that how to go about it, how to approach that question. So that approach is going to help you not only in this proptosis, not only in this ophthalmology, but in every clinical scenario. So you have to go by the history, then you have to go by the local examination, then the systemic examination, and then we will be taking the help of the investigations as well as the imaging. And you will see this also. See why they have reduced the number of questions this time from 300 questions, just 200 questions. Obviously, this means that your question is going to be very, very large, and you will have handful of information there. Now, every time when you have this handful of information, it is always not beneficial, because you may be messed if you do not know how to use these resources. If you remember, I had posted this also once, that no matter how many resources you have, if you do not know how to use them, you will be in chaos. So you will have to actually go in the step ladder pattern. You have to look at the history, look at the examination, and then finally go to the investigations and imaging. Only then you will be able to make a proper diagnosis. So what are the things that you're going to take up in history? So if I am seeing that this case is revolving around the proptosis or the exophthalmos, always see the age of onset. If you remember in our previous integrated session of ophthalmology and radiology, Dr. Rajat said once that tumors are like real estate. So position and the age are very, very important. And I will say that that was a wonderful piece of advice. So you have to look at the age of onset, because your answer will change just by the age also, if everything is same, whether it is in adults or whether it is in children. What is the duration? What is the progression, whether it is constant or intermittent? Now the moment you see it is constant, some of the features are out. The moment you see it is intermittent, other diagnoses are out. So you are kind of, converging. It should always be in a pyramid pattern. When you are going towards the question, more and more lines you are crossing, more and more apex you are reaching, and ultimately answer will be one at the apex of the pyramid. That always see the variation with the posture and the strain, whether it is followed by the diminution of vision or not. That is again a very important thing, whether it is approaching the optic nerve or it is bypassing it. Is it stationary? Is it progressive? And the associated field effect. So moment you are going to answer these questions, I'm damn sure that 50% of your options will be ruled out there. Then you have to see is there is any history of pain, diplopia, very, very important. Think about the cavernous sinus thrombosis. If you're thinking about the keratoconus fistula, yes, we will have diplopia there. We will be having the ocular motility restriction would be there. If I'm thinking of the encephalocele, if I'm thinking of fistulas, trauma history is again very important. If I'm thinking of the cavernous sinus thrombosis or the orbital cellulitis, I should have the systemic features, fever, chills and rigors, other systemic symptoms. Then history of cancer. Maybe your patient is known case of carcinomas, and lymphoproliferative disorders are again very, very common in orbit. And of course, the very important thyroid eye disease, diabetes, hypertension, HIV, and the syphilis. So when you are there with all these backgrounds, it will become very easy from the options that what are the options that could purely be neglected, and mostly you are left with two. So wo jo two ka chakkar hai 50-50, that is again very, very important, because it is very easy most of the times to rule out two options. But in order to go for that final 50-50, you require definitely imaging and the investigations. Then the two important views that we are going to use in order to assess the proptosis. One is your Nafziger's view. Now, can you see here, when you are going for this view, you are actually standing on the head end of the patient. So when I'm standing on the head end of the patient, and these are the two eyes, one of the eye is looking propped out. I can easily find out. Can you see in this picture? In this picture, the left eye is obviously proptos. So you can easily see something like this. But the other way is that you are standing. This is your worm's view when I'm standing at the foot end of the patient. So when I'm standing at the foot end of the patient and I'm seeing that one of the eye is more towards me than the other, then again, I'm going to find that this is proptosis. So very quick, very easy, convenient method, standing just on the clinical bedside of the patient. And these are the things which are actually in a trend nowadays to be asked. As if you remember, Dr. Nachiket told us that how to do things is more being asked nowadays. So this is just quick bedside examination. You can easily find out that whether there is enough thalmos in the other eye or there is actually proptosis in one of the eyes. So remember the two views name, right? All right. Now we'll be discussing the clinical scenarios, and we will be aided by Dr. Rajat in the imaging of these conditions, so that there is no doubt finally that this is a case of thyroid eye disease or cellulitis or fistulas or malformations. So let us see this scenario where a person is coming to me with the proptosis, right? So in the first one, whether it is unilateral or bilateral, you have a lid retraction. Now, I would also like to say one thing here, that most of the time, thyroid eye disease and proptosis go together. So we always think that proptosis is, of course, the most important sign of thyroid eye disease. So though it is the most important, but it is not the most common. So there is always a difference between most important, most common, earliest, and like this. So examiners also play with the words. You have to be very, very careful. The most common sign that you are getting in thyroid eye disease is not proptosis, it is the eyelid retraction, and most of the times it is the upper eyelid retraction. So eyelid retraction if I am getting, eyelid leg if I am getting, unilateral, bilateral, male, female, does not matter. It is found in all. Then if I am having a heat intolerance, because mostly it is the Graves' eye disease. Now I will try to lift the barrier here. Don't think that the patient is euthyroid. If my patient is euthyroid, then I cannot have proptosis. No, not at all. See, 90% are hyperthyroid, but again 10% people could be hypo also and euthyroid also. If you remember, this question came last year in E 2020, and all of you said that, ma'am, they had saying that the patient is euthyroid. Why to think thyroid eye disease? No, it could be euthyroid also, it could be hypothyroid also. Then also we will think about the thyroid eye disease as the most common cause of proptosis in adults, both unilateral or bilateral. And certainly it's more common in females, but it could be in males or females also, along with the thyroid brew or the enlargement. So I would request Dr. Rajat to tell us about the imaging findings, what we are going to get in the thyroid eye disease.
Thank you, Dr. Niha. I will close your screen.
Yes.
Okay. Okay. When we talk about proptosis or exophthalmos, I feel that when you look at these clinical questions, the history and the clinical examination that has been given plays an extremely important role. And one of my message to everybody is that whenever you are reading those clinical questions, please try to pick up those salient points, okay? And just try to identify those salient points from the imaging. That will help you. Now, if I look at a thyroid ophthalmopathy, I hope my screen is visible, Dr. Niha. Can you see my screen sharing? Is it visible?
Just a minute. I don't think so. I cannot. Yes, now it is visible. Yes.
Okay, all right. So now, if you look at a thyroid ophthalmopathy, we know that the extraocular muscles are predominantly involved in thyroid ophthalmopathy. So if you look at the pattern of the thyroid ophthalmopathy muscles that are involved, they can be easily remembered with this mnemonic, and that is I am slow. Now, whereas I stands for inferior rectus, M stands for medial rectus, S for the superior group, and L for the lateral rectus. I have also written there the thickness, the normal thickness of these muscles for your reference. Though the way the paper patterns are being created nowadays, it is extremely unlikely that somebody is going to ask you those values. But yes, the earliest muscle to be involved or the pattern of the muscles to be involved is something that could be there in one of the choice. Okay. So if you look at the imaging, now what you see is that's a typical CT scan showing thyroid ophthalmopathy. Now look at this medial rectus muscle. Now, if you see, this is the medial rectus muscle and this is the lateral rectus muscle, and in the center you could see the optic nerve. Look at the muscle belly of the medial rectus. It is so bulky. But a hallmark feature here is look at the tendon. The anterior tendon is spared, and this is called as tendon sparing. Now, in radiology literature, this has been given a typical name which is called as a Coke bottle appearance, because what is happening is it is bulbous in the bulk and then the bulky in the muscle part, whereas the tendon is spared and is thinned out. So it is almost like a bottle of a Coke. So Coke bottle appearance, tendon sparing. This is a typical pattern in which it is involved, usually bilateral. Always think of, in an appropriate clinical scenario, think of thyroid ophthalmopathy. Okay, so I don't think there is much more than the imaging in the thyroid ophthalmopathy. Over to you, Dr. Nia.
Thank you. I think this I am slow is quite good because in our times we used to remember IMS Lucknow, but I think this I am slow is even better. So thanks for the mnemonic. All right. So as rightly shown by the Dr. Rajat, the typical tendon sparing. So I'm going to discuss one more thing which often creates a confusion between the thyroid eye disease and the orbital pseudotumors. Now, orbital pseudotumors, you know, it is one of the important causes of unilateral proptosis. And these are called as pseudotumors because they are presenting as a mass. Now, though they are inflammatory lesions, the chronic inflammation is there, and mostly we are going with the diagnosis of exclusion. Now, whenever we are going with the diagnosis of exclusion, it becomes very important for us to rule out the other things. If I have ruled out the thyroid eye disease, I have ruled out the tumors also, I have ruled out the other systemic features, only then I can say that it is a case of orbital pseudotumors. And you know, because the pathology is mainly inflammatory, it is also called as the idiopathic inflammatory orbital syndrome. Now this can be presenting as a case of which is resembling to the cavernous sinus thrombosis. Because of the inflammation, we have the acute presentation, we have pain, we have got edema, and you know, a painful ophthalmoplegia and this edema of the conjunctiva, which we call it as chemosis. This is actually present in 50% of the patients. So very oftenly we get confused. We send the patient to the IPDs for admission as if it is a case of cellulitis or as if it is a case of this cavernous sinus thrombosis, but we could not see any motility defects in the early stages. Nevertheless, if this patient is coming from a long-standing situation, I can have fibrosis and then I can have the motility defects also. So definitely we require certain kind of imaging where I could find out whether or not this is a case of the thyroid eye disease. Because if this patient is presenting in the age group of the adults, see, in the children, you know, it's not very common. And whenever we are getting the proptosis in the adults, the first thing that clicks our mind is the thyroid eye disease. And I think there is no problem. That is a right strategy. Obviously, I say dictum is proptosis in adults means thyroid eye disease. But we will require the imaging to exclude this thyroid eye disease. So I would like to ask Dr. Rajat to throw some light on the imaging. How will they be getting the pattern in the orbital pseudotumors?
Thank you, Dr. Niha. I will close your screen and I will add mine. Just give me a sec for that. Okay. I hope you can see my screen.
Yes. Yes.
Okay. All right. So when we look at orbital pseudotumor in the imaging, it is one of a very, very common differential of thyroid ophthalmopathy. The usual differential, the points that you have to see in the clinical history is as such, there is no pattern of involvement, a typical pattern like we discussed about the thyroid ophthalmopathy. The second is thyroid ophthalmopathy is usually bilateral, whereas an orbital pseudotumor is usually unilateral, though bilateral cases have been reported, but it is usually unilateral. And when you look at an MCQ, it is a standard pattern that is being given rather than the uncommon pattern about that particular disease. If you look at the image, now this is an image of a patient who was suffering from an orbital pseudotumor. Again, if you look at the involvement of the extraocular muscle, now this time you could see the involvement of the lateral rectus onto the right side. And if you see this bulkiness is extending into the tendon. So the common appearance of Coke bottle appearance in a thyroid ophthalmopathy with a tendon sparing is not seen in an orbital pseudotumor, and it is the entire muscle along with the tendon is involved. From the imaging aspect, this is the the one of the most useful criteria to differentiate a thyroid ophthalmopathy from an orbital pseudotumor. Obviously, once you're looking at a complete clinical scenario, you have to pay attention to the rest of the things that have been mentioned in the question. Okay, over to you, Dr. Neha.
Um, we would like you to tell us about the imaging of the cavernous sinus thrombosis as well as this keratoconus fistula, so that we get to know, because this orbital pseudotumors actually is the diagnosis of exclusion. Suppose the patient is coming to me with the acute features, it could be a pseudotumor also, it could be thrombosis, it could be a fistula. So please, so that we can compare it at one place only, we can go with this.
All right. So if I look at the keratoconus fistula, as we know that a keratoconus fistula is a communication between the internal carotid artery and the cavernous sinus. I feel that if the examiner wants you to mark the answer as a keratoconus fistula, an important point that they will be giving you in the history, probably Dr. Niha will tell more about that, is the type of exophthalmos that you will be getting in that, and it's a characteristic pulsating exophthalmos that you will be getting. Now, important imaging feature that you will be getting in a keratoconus fistula, as you can very well appreciate in this particular image. See what is happening. It's a fistula. I don't think you need to mug it up. Just think about that. It's a communication of a venous channel with an artery. And what is the fundamental difference between an artery and a vein? The pressure. The artery has got very, very high pressure flow. Veins have got very, very low pressure flow. So once there is a direct fistulous communication between an artery and a venous channel, the pressure gets transferred to that vein. And once the pressure gets transferred to that particular venous channel, all the tributaries which are associated with that will also get dilated. Now, what are the important tributaries of the cavernous sinus? Recall your anatomy knowledge. You know that the superior ophthalmic vein is a major draining vein of the cavernous sinus. So dilatation of a superior ophthalmic vein is a very, very important sign of a keratoconus fistula. In a patient who is having a pulsating exophthalmos and on imaging you see dilated superior ophthalmic vein, the first answer that should come to your mind is a keratoconus fistula. In this CT image, you could see that on the left side, this superior ophthalmic vein, which is going into the left orbit, is dilated. Obviously, you could see some of the collateral channels over here into the left cavernous sinus, and the cavernous sinus also appears bulky over here. If I show you another case, this is an MR where you could see some of the flow, the collateral channels over here. Along with that, you will see markedly dilated superior ophthalmic vein onto the left side. Another patient where you could see bilateral superior ophthalmic veins are dilated. So all these images are pointing towards a case of a keratoconus fistula. Now, when we talk about cavernous sinus thrombosis, again, as the name says, there is a thrombosis of the cavernous sinus. Okay. Now, when you look at the proptosis pattern, as we see in a keratoconus fistula, which is more of a pulsating exophthalmos, a keratoconus sinus thrombosis, because now the sinus has undergone thrombosis. So you will not have that, and that again something that will mimic a lot with the pseudotumor. Again, the imaging will play an extremely important role over here. The pseudotumor is involving the orbital component and the muscles are involved, whereas the cavernous sinus, what you are seeing is the involvement of the cavernous sinus. If I show you the image, if you recall your anatomy, now we have cavernous sinus and the lateral wall of the cavernous sinus is concave. But now the cavernous sinus has become thrombosis. So what happens? First thing is the cavernous sinus is bulky. There is loss of flow void of the normal cavernous sinus on the MR imaging. However, if you do a contrast enhanced CT, you will see bulky cavernous sinus with filling defect within the cavernous sinus. As you could see, normally these walls are concave. If you see this wall, the lateral wall is concave. If the outer wall become convex, that means the sinus is bulky and something is filling the cavernous sinus. Okay, and you see the filling defect within the cavernous sinus on a contrast enhanced image, definitely you are dealing with a cavernous sinus thrombosis. Sometimes you can see the thrombosis extending into the tributaries or the vessels. As you could see, that thrombosis is extending into the further vessels. But the bulky cavernous sinus, the convex lateral margin, and filling defect within the cavernous sinus are the hallmark imaging features of cavernous sinus thrombosis. Over to you, Dr. Neha.
Yes, thank you so much. So that means we have got clear-cut demarcations in the imaging studies when we are dealing with the patient of the keratoconus fistula and when we are dealing with the patient of cavernous sinus thrombosis. Now, if you are going clinically, always remember we had discussed this, the PCB in the keratoconus fistula. So you will definitely be getting the pulsatile proptosis. The P, C is your chemosis. That is your edema of the conjunctiva, and B is the brew. And I don't think that you are going to get this triad any other place. So if you are getting this triad along with this imaging, you are 100% sure, you are dead sure that this is a case of keratoconus fistula. But if you are having a similar kind of picture, you are having similar kind of motility defects, involvement of cavernous sinus, but you are not getting that typical triad, you are not getting those particular imaging, that means it is a case of cavernous sinus thrombosis. Now, cavernous sinus thrombosis, sometimes Dr. Rajat is confused with the orbital cellulitis also. Like I also remember once there was a 14 years boy and he was admitted to our site thinking that it is cavernous sinus thrombosis, and we were doing 4-hourly monitoring, everything was done. But next day when we had gone for the x-ray and when the x-ray was going on, whole of the pus material came out in that kidney tray and it was actually a case of orbital cellulitis. So what would you say about this?
Just give me a sec.
Yes.
Can you just repeat your question?
I'm saying that the clinical findings of the cellulitis as well as the cavernous sinus thrombosis are quite common sometimes, and sometimes we are admitting the patient thinking that this is thrombosis actually, but and we find out that it was cellulitis. So because you know, it is always better to overestimate, over diagnosis is always better than under diagnosis. So as our consultants used to say, that always admit a patient if there is query cavernous sinus thrombosis. So we had also done this on our side while I was doing my PG. We had admitted a 14 years old boy and we were doing intensive monitoring, everything on. And next day when we had gone for the x-ray and then we had planned for the CT scan, while the x-ray was going on, you know, whole of that pus material came out in that kidney tray and everybody was relieved that it is actually a case of cellulitis and not thrombosis. But maybe we had gone for the imaging. So what will be the acute difference we would have got on the imaging by which we could have find out that this is not thrombosis, this is actually cellulitis only?
Yeah, Dr. Neha, very, very relevant question. And this is the whole idea about DBMCI teaching, and that is what I try to tell them, that do not just limit your knowledge at one place. Now, please understand that a cellulitis and a thrombosis is a common differential, not just in eye, but at many other places. Now, when you are attending your surgery posting, the commonest differential of a DVT is again a cellulitis. Now, because both will have a similar feature, and these are the places where imaging plays an extremely important role. Now, if you recall your surgery postings, a patient of a unilateral limb edema, the patient is coming, you have only two differential, either it's a cellulitis or a deep vein thrombosis. The same is the thing that is happening in the eye. Now you have almost, I will not say the exactly, but almost similar clinical appearance of a cavernous sinus thrombosis or an orbital cellulitis. Now just recall what you do to differentiate a deep vein thrombosis from a cellulitis in leg. Now what do you look? You look, deep veins are patent. You do a Doppler, you look at if the deep veins are patent, that means there is no deep vein thrombosis and it is orbital cellulitis. Oh, sorry, it is the cellulitis of the leg. That is the same thing that you are doing in the eye also. Now the changes, and let me show you a case of orbital cellulitis. Now see this. Now what is happening? see the left eye, see the marked thickening of this area. Now you see this is a classical preseptal cellulitis with marked thickening and a heterogeneity in the preseptal space. Now the same can be seen because again there is a lot of engorgement that is happening in a cavernous sinus. So the same appearance can be seen in a cavernous sinus thrombosis, but what is the difference? In an orbital cellulitis, look at the cavernous sinus, and the cavernous sinus will be absolutely normal. The concave margin, I'm not carrying the exact image of that. The concave margin, the lateral margin of the wall of the cavernous sinus will be maintained. On a venous phase image, the enhancement will be seen as usual. There will be no filling defect within the cavernous sinus. So if you are seeing just preseptal soft tissue thickening with heterogeneity and enhancement and a normal appearing cavernous sinus, you are dealing with a case of orbital cellulitis. If the cavernous sinus is bulky, showing filling defect and a convex lateral margin, think of a cavernous sinus thrombosis.
Yes. Thanks for the wonderful insight. Carrying on with my discussion on proptosis. All right. So I think the confusion about the thyroid eye disease, the cavernous sinus thrombosis, keratico-cavernous fistula, and the orbital cellulitis is very, very clear. Now I am going to present you another clinical scenario where we are getting the history of trauma. We are having the severe conjunctival chemosis, pulsatile proptosis, we have a orbital brew. So this you can easily answer now. This is having the typical history of trauma and we have got the PCB history. So what is the answer? This is your keratico-cavernous fistula. Now what are the other clinical scenarios we can get? The other one is we have got a middle-aged woman, slow growing proptosis, we have got retropulsion, we have got axial proptosis. I hope there is no confusion between the axial proptosis and the abaxial. Abaxial means it could be downward, it could be lateral in the any other direction. Then we have got increased hyperopia along with the unilateral involvement. Now this is a typical case of cavernous hemangiomas. Cavernous hemangiomas, now you will be amazed to see that why there is increased hyperopia in these cases. We have got increased hyperopia because this hemangioma is actually leading to the elevation of the retina. Now, due to this elevation, do you remember the acquired hypermetropia in cases of the CSR? So there also we were having the elevation of the macula. So here also we are having the elevation of the retina due to these hemangiomas, and not only do we get the increase in the hypermetropia, that is your farsightedness, we also get the distortion of the vision. So I think a very important clinical scenario where you are having a middle-aged woman along with the axial proptosis, unilateral with distortion of vision and with the increased hypermetropia, you have to think about the hemangiomas, right? Then if you go with the another important thing, and that is your the orbital varix. Now orbital varix ke bare mein if I talk about, this is a comparatively rare condition. Only 1 to 3% of the patients are presenting with this varix. So what is this varix? Sometimes even this varix is also resulting from your keratico-cavernous fistula. Varix is nothing but the dilated veins. So I can get this dilated veins due to the AV malformations also. Whenever a high pressure area is actually bleeding into a low pressure area, there is a fistulous communication. But definitely you are going to get certain points which will differentiate this varix from the keratico-cavernous fistula. For example, I will not be getting the PCB now. Now they will be telling you about the intermittent proptosis. So the moment you hear this word intermittent proptosis, think about varix. Why intermittent? Because every time the blood is not going into the veins. So the moment high pressure blood flow into the veins, there will be intermittently proptosis. Only type of proptosis that is increasing in the stressed up position, that is also called as the stress proptosis. Increased while crying, increased while bending forward, increased in the Valsalva maneuvers. And that is why you will see of late in certain books, they have also introduced a term called as Stress proptosis. So stress proptosis means somewhere orbital varix. That is again very, very important. Then another important thing is if I am having a rapid onset proptosis, if I am having rapid onset proptosis along with the motility defects also, but I'm not getting any history of thyroid, I'm not getting any history of trauma, I am not getting any other signs of fistula, but we have pain, we have diplopia, and somewhere I have some evidence of primary tumors, mostly lung tumor in the males and the breast tumors in female. What you have to think is the metastatic tumors. So yes, the final diagnosis will depend upon imaging, but yes, in my mind, I'll be having some clue, because when we are sending the patient for the imaging, we are also talking to each other, giving certain clues that I'm thinking on the terms of fistula, I'm thinking on the terms of cavernous sinus thrombosis, or the thyrangiomas, the hemangiomas, or the varix. So we will obviously be concerning the case also. So somewhere in the corner of my mind, I'll be having these things that this patient could be a case of orbital tumors. And if you remember, I told you that the most common tumor in the eye is, of course, the metastatic tumors. We do not have the primary tumors as the most common tumors. Then another important thing where you can have a clinical scenario, a very typical one, where you can just tell the answer going by the scenarios. If I have a child just 5 years old, okay, and I'm having the upper nasal quadrant mass. Now they can tell you this in the theory, or they can also give you a image. Okay, image based question could also be there, that this is a 5-year child coming with this mass and it is painful. It has been having some episodes of proptosis, but a very important thing is that it is actually worsened by the respiratory tract infection, upper respiratory tract infection. Then it is very, very hallmark, and sometimes they will ask you just this question, that proptosis related with URTI. Then your hallmark answer will be your lymphangiomas. Of course, we'll go with the MRI for seeing the fluid level. So for this, we'll be taking the help of Dr. Rajat. But if they are telling you the proptosis with URTI, first thing that you have to go about is your lymphangiomas. Another thing, if I am having a child 7 to 8 years, so a child 7 to 8 years, history of nose bleeding. So if this child is coming with the nose bleeding, and I will have the collection of the blood here, so there will be a bluish discoloration. It is unilateral and lymphadenopathy. There is an involvement of lymph nodes. What do you have to think of rhabdomyosarcoma? Rhabdomyosarcoma is the most common primary intraorbital tumor. So if you have not gone through the tumors, I would say, okay, first see that flow chart that I always give you in the classes also, that you have got the most common intraorbital, intraocular, primary, and then in children or in adults. So most common primary intraorbital in children is your rhabdomyosarcoma. So whenever you are having this history of nose bleeding with the bluish discoloration along with the lymph node involvement, rhabdomyosarcoma. Now, obviously, if they have given you imaging, then that is another feather in the cap. And obviously, the final diagnosis, you know, when I am not having any doubt about it, will come by the imaging only. But if by far they are asking you just in the clinical way, then these will be your absolute answers. Another rarer thing I will talk about is the encephalocele. So again, very, very rare. But when you are having a question, okay, rarer things are often asked. So encephalocele is nothing but, can you see, there is a herniation. Intracranial contents are coming through the defect. So usually, you know, in cases of encephalocele, if they want to ask you, then they will definitely give you some history of trauma also. They will give you certain, you know, clue about the transmitted pulsations. They can tell you about the brew. They can tell you about the defect in the base of the skull, something like this. And then we have to confirm it with the imaging. So I would request Dr. Rajat to throw some light on the imaging of the varix, encephaloceles, and the tumors. How should we go about them?
Is my screen visible?
Yes, yes.
Okay. All right. So um, now when we talk about these vascular, let's start with the vascular abnormalities. And we have spoken about the keratoconus fistula. The two more important abnormalities that we need to talk. One, Dr. Niha has already, in fact, she has already beautifully described almost every part, including the imaging. So I'll just tell you, see what happens in a clinical question is you have to pinpoint certain features, you have to club it with the imaging, and just you have to reach to a diagnosis. Like when we said that it's a pulsating exophthalmos, the first thing that should come to your mind is a keratoconus fistula. Just quickly look at the imaging, look at the dilatation of the superior ophthalmic vein, bulky cavernous sinus, and your diagnosis is keratoconus fistula, period. Okay. Now, then you have got slow flow vascular malformation. Now, when you look at the slow flow vascular malformation, the two important one that is coming over here is an orbital varix and orbital or a cavernous hemangioma, which is considered to be one of the commonest vascular tumor in the orbit. Now, when you look at the hemangioma and when you look at the orbital varix, the biggest challenge that it comes with, if you have a simple contrast enhanced CT, probably it will be extremely difficult to differentiate them just on the basis of a single image. So look at the clinical history. As Dr. Niha has rightly mentioned, in an orbital varix, a hallmark point that you're going to see in the clinical history is a intermittent proptosis. That means it will increase on Valsalva. So please try to identify this important point in the clinical in the question, that whether it's a positive point or a negative point. If they say that the proptosis does not increase on Valsalva, that means they are trying to rule out varix. If they say it increase on Valsalva, that means they are trying to give you varix into the history. Now, if I show you the image on a non-contrast CT, you will see an ill-defined soft tissue lesion into the retroorbital space, which may have some calcific foci, which are called as phleboliths. So these phleboliths can be seen in your orbital varix also. It can be seen in a cavernous hemangioma also. Okay. Now this is a non-contrast CT. If you will take a contrast enhanced CT, now if it's a varix and you take it on a Valsalva, you will see increase in the size and it will see a homogeneous enhancement similar to the cavernous sinus. Okay. Hemangioma will also show nearly similar enhancement, but it will not increase in the size on Valsalva. Okay, I'll show you an image of a hemangioma. That's a T2 weighted MR where you could see a cavernous intraorbital hemangioma, which will not change in the size, which will not have these intermittent kind of proptosis. Now, she has also mentioned about a lymphangioma. I do not have the image of a lymphangioma at this point of time, but a contrast enhanced image will play a role over here. A lymphangioma by definition has lymphatics. So you will not expect too much of the enhancement in a lymphangioma, and that will help us in differentiating whether it's a venous malformation or whether it's a lymphatic. A lot of time in a clinical practice, we have a combined veno-lymphatic malformation, and that becomes a real challenge. But in our exam, it is unlikely to get those combined malformations. Okay. Now, when we look at an orbital encephalocele, again, I don't think that we need to go too much into the detail about that. It's simple. Encephalocele is the herniation of the brain parenchyma. As you could see on this T2 weighted coronal image, there is a lesion, which is a markedly hyperintense lesion extending into the orbit. But on a single image, you cannot really identify what is happening. If I scroll through the image, you could see a communication with the frontal lobe. So if it's only the meninges that are herniating, it's meningocele. If a part of the brain that is also herniating, that's an encephalocele that you can easily appreciate. Sometimes a single image might not be useful. When you see the entire stack, you will be able to identify it in a much better way. Orbital tumors. Now, when you talk about orbital tumors, some present with proptosis, some do not present with the proptosis. So when you look at the orbital masses, when they are pushing the orbit forward, obviously they will present with proptosis or exophthalmos. In a young adult, in a young boy, if you see an orbital mass, the first possibility that should come to your mind is an orbital rhabdomyosarcoma, okay, originating from the extraocular muscles. The orbital extraocular muscles is the commonest site of rhabdomyosarcoma in the young boy. In females, though the boys are more commonly affected, in female uterine rhabdomyosarcomas or vaginal rhabdomyosarcomas are more common. But orbital, if you're gonna look at it, you will see a mass with a multi-compartmental mass with heterogeneous enhancement into the orbit. And then the first diagnosis that should come to your mind is a rhabdomyosarcoma. Okay, another patient, we could see a small rhabdomyosarcoma, but it does not respect the compartments. Okay, intraconal, extraconal compartment, they are not being respected as in the cases. So you see a mass which is involving the extraocular muscles. Obviously, clinical features have been very well explained by Dr. Niha. Then you are thinking about an orbital rhabdomyosarcoma. One more tumor that you should think is an optic nerve glioma. If the examiner wants you to mark the answer as optic nerve glioma, again look at the salient feature. One of the classical history that you're going to come across is inherited syndrome like an NF1, a neurofibromatosis 1. If you're going to see this history and an orbital lesion, that think of an optic nerve glioma, where you could see the bulky, complete bulky optic nerve. The important point is that it has to be differentiated from optic nerve sheath meningioma, where you could see the optic nerve seen in the center, and it is the nerve sheath that is thickened and enhancing, which is called as a tram track pattern in an optic nerve sheath meningioma, which will not be seen in optic nerve glioma. Always look at the clinical history. The history of neurofibromatosis 1 is given. Examiner is more likely pointing towards a diagnosis of a optic nerve glioma. Okay, I think that is all from my side about the various images that are needed. Over to you, Dr. Niha.
Yeah, thanks a lot, Dr. Rajat. Yes, rightly mentioned about the optic nerve glioma. See, it's not a very common cause of the proptosis. And if the examiner wants to ask certainly about the optic nerve glioma, they will be telling you about the NF. So the typical cafe au lait spots and all those things will be there. And plus, 15 to 20% of the patients will develop the optic nerve compression neuropathy. So you will definitely have a history of vision loss also. Plus, they will not be presenting as an acute proptosis as we were having in the thrombosis or the fistula or the cellulitis. So you will definitely come to know that this is not the thrombosis or the other known, very well known causes of the proptosis. So let me first come up with this. So we have, I think, almost covered all the important causes of proptosis, and Dr. Rajat has beautifully explained the imaging part. Before ending the session, I would just like to give you some, brief points, just shorts, which will help you in solving the questions related to the proptosis. So the first is, if I'm having the proptosis with the leukocoria, that is a whitish reflex, think about retinoblastoma. If I'm having the unilateral fast progressing proptosis with fever, if the child is toxic, there is pain, that means unilateral proptosis that is painful and acute in a child, think about orbital cellulitis. If I'm thinking about unilateral axial proptosis with a vision loss also, then you have to think about the optic nerve glioma that I was talking about. Now coming to the bilateral. So bilateral proptosis with fever and the systemic toxemia, think about cavernous sinus thrombosis. If I have a pale child, there is a bleeding from the gums, unilateral or bilateral, then think about leukemia. I think other day, one of you messaged me and asked that why to look for eye involvement in leukemia. So there is very important eye involvement. Then we have got unilateral proptosis, pain, fever, hazy cornea, and loss of vision. Always think about the panophthalmitis. If there is a sudden dramatic proptosis, acute proptosis with the recent URTI, so I told you it could be a lymphangioma. If there is a gaze evoked amaurosis, then you have to think about the orbital apex tumors. Then if you have a mass in the lacrimal region, then that could be a adenoid cystic carcinoma. Long history but painless, think about pleomorphic adenoma. Then tinnitus, if they're giving you tinnitus history, think about AV shunts, proptosis increasing on Valsalva or straining, that is your stress proptosis, orbital varix, spontaneous unilateral periorbital bruising, amyloidosis, and finally spontaneous bilateral bruising. If it is there, then it is a neuroblastoma. So some of the tidbits that will help you in solving the instant questions along with the integration of ophthalmology and radiology. So I think, Dr. Rajat.
Yeah, very well. I think a very well conducted session, Dr. Niha, and I'm very sure that the students who have attended the session till the last, the session is very, very useful for them. Though it was a slightly lengthy session, and that is why we were not able to take the doubts in the middle. But you can put the doubts in the comment section, and we will be answering all of them. I'm very, very sure that the examiner will ask a question from the ophthalmos. This is the uppermost limit of the exophthalmos that you need to be aware of. And there are a lot more videos of in this integrated series that are coming onto the DPMCI YouTube channel. And just keep watching them, and like the channel and subscribe to the channel. Do share it with your friends, because as my daughter says, sharing is caring. So
Yes.
do not think that if you will be sharing your information with your friends, you are at loss. The God looks at all these things, and I'm sure that this will be very, very useful. Though there are some information that I would like to share with our student who have trusted on us. A lot of students have asked me that, sir, why you are doing the private session for this. The reason was pretty simple. I have never believed on those. I always believe that the knowledge should be given to everyone, but that the students this. So I thought that it should be limited to only those people who have trusted on us, and that is why we are having a special plan session for the students who have enrolled with us. So do join us. You will be getting the Zoom link and the link on your DBMCI live app for a live session with me and Dr. Thamim today at 8 p.m. So all the best and keep reading, and I'm sure you all will rock in the exam. Thank you very much for this session, and thank you very much, Dr. Neha, for starting or taking this initiative of this integrated learning at DBMCI YouTube channel.
Thank you, Dr. Rajat. Thanks for spending so much of time for us. And you guys, please keep on, sharing. And as Dr. Rajat rightly said, sharing is caring. Knowledge बांटने से बढ़ती